Much for joining us for today's STI Clinical Update webinar. We're so lucky to have two fabulous presenters, Dr. Jacobson and Dr. Hanft, to talk about syphilis in pregnancy. My name is Dr. Sharon Adler. I'm a longtime clinical faculty at the California Prevention Training Center, and I'm going to be emceeing today, as well as facilitating questions. And also, I'm going to start off by giving you a little bit of introductory slides about the CAPTC and some Zoom housekeeping, and I'll also be introducing the speakers in just a moment. So welcome in the room again, everybody. So before we start, here's a brief introduction about the California Prevention Training Center at UCSF. We are a multidisciplinary training and capacity building assistance center. We're sponsored by the CDC, and we're one of the members of the National Network of STD Clinical Training Centers, otherwise known as the NNPTC. We provide virtual, as this is a virtual training, in-person training, TA, clinical tools, and we're part of a clinical consultation service, which I'm going to talk about in just a moment. And we have a fabulous website if you want more information about the California Prevention Training Center or the NNPTC. Links to both of our websites are at the bottom of this slide. The STD clinical consultation site is something which will be a great resource to everyone joining this Zoom webinar. So if you have a tough STI question, syphilis question, we often get lots of syphilis questions. This is an online clinical consultation site. You can go to the site, put in your clinical consult, and we will respond in 1 to 5 business days, depending on the urgency of your consultation. So a great resource for all of you to be aware of. In terms of disclosures for today's webinar, we have no disclosures. Regarding CME, today's training is offered at 1.25 CME units at no extra costs. And there's a whole bunch of details regarding CME and how you can get it. So I'm going to go through these with you on the slide. So to earn that 1.25 CME units, you need to know that you have to have registered for the webinar by yesterday, November 19th at 3 o'clock. You must attend the webinar live and in full. And so when you sign on in to this Zoom webinar, your attendance is recorded. And then you also need to complete the post-course survey evaluation by November 30th. So you will all receive, everyone who is registered is going to receive a post-course survey evaluation. It will be sent to you within 24 hours. And the email is going to come from training@NNPTC, and that will give you a link to the post-course survey evaluation. So make sure that the training@nnptc.org is part of your safe and trusted senders list. If you meet all those CME notifications, then in January 10th, you'll receive an email from us, CAPTC at UCSF, which gives you a link for you to claim your certificate through our CME provider. And our CME provider is the University of Nevada, Reno School of Medicine. And again, that CME notification will be sent to the email address that you used to register for this course on the NNPTC website. A couple other details, housekeeping details. You don't need to request the slides. We often get questions, am I going to get these slides? This presentation is great. The slide handouts and a link to the webinar recordings will be made available to everyone who is registered approximately 2 weeks after the webinar, after today. And so you'll receive a notification that these materials are available, and that email will come from us, captc@ucsf.edu. So you don't need to request our slide handouts. Everyone will get these. Okay, finally, a couple of things about today's Zoom webinar. I just want to say we're up to 323 participants. Fantastic. So you will be able to interact with the presenters via Q&A. So look for that Q&A icon. It looks like this in the middle of my screen. You can click on it, type in your question, and then click send. And you can submit questions up into the last 2 minutes of the Q&A session. I will be answering some of these questions if I can answer them during the presentation. And then the two presenters, some of the questions will be directed to them, and they'll be answered live at the end of their presentations. If they're technical questions or administrative questions, our clinical admin team, Elizabeth Olson and Lauren Blakely, will answer those. Your microphones, video, and chat will be turned off because we have so many participants, which is fantastic, but we just can't be able to see all of you and have you all chatting with each other. But you can use the Q&A for questions. If there are any additional questions, feel free to contact our clinical program manager, Elizabeth Olson. Her email is on this slide. All right, and so now it gives me great pleasure to introduce our two speakers. We're so lucky to have Dr. Kathleen Jacobson. She is the chief of the California Department of Public Health STD Control Branch. She is an American Academy of HIV Medicine and HIV Medical Association HIV specialist, and she's board certified in family medicine. And she has over 30 years experience working as a clinician. I said that she's currently the chief of the STD Control Branch at the California Department of Public Health. She's a recent HIV/TB care and treatment advisor for the U.S. CDC to the country of Uganda. She was a previous medical director of the LA Regional Pacific AETC, and she's a previous associate professor of clinical family medicine at the University of Southern California Keck School of Medicine. So it's fabulous to have her with us. And we also have Dr. Wyatt Hanft. He is our sexually transmitted infectious disease fellow at UCSF, and his training is supported by the California Department of Public Health STD Control Branch, as well as the California Prevention Training Center. He works with both of these organizations with statewide STI surveillance, preparedness, response, and provider education. And his clinical activities include an outpatient family practice at UCSF, as well as working at the UCSF's Anal Neoplasia Clinic and the Oncar Center. So without further ado, I'm going to stop sharing my slides and turn the presentation over to Dr. Jacobson.
Great. Thank you, Sharon, for such a nice introduction. And I want to start by thanking Wyatt, who has prepared all of these slides for you today and for me. So thank you, Wyatt. Today's session is focused on the frontline primary care provider who is really seeing these patients as they come in with syphilis and potentially caring for pregnant individuals who have syphilis in pregnancy. We've also made a special invitation to federally funded clinics that are federally funded clinics and healthcare systems that reside in zip codes where the highest morbidity of syphilis and congenital syphilis is occurring in California. Next slide. And before I move on, I just want to welcome everybody and thank you all for coming today. So our learning objectives today will review the epidemiology of syphilis and congenital syphilis in California. We'll describe syphilis diagnosis, treatment, and follow-up during pregnancy. We'll apply the California Department of Public Health and the American College of Obstetrics and Gynecology screening recommendations during pregnancy. And we'll compare traditional and reverse screening algorithms for syphilis. Next slide. So starting with syphilis and CS epidemiology in California. So as you can see, syphilis hit an all-time low around the late 1990s and early 2000s in California. And then, although there was sort of a gradual uptick around 2012, 2013, California syphilis incidence rates began to increase. And by 2019, they were double the incidence rates in the United States. Next slide. And it's been, in 2022, incidence rates hit an all-time high. And they're just now beginning to stabilize in 2023. Next slide. And you can look at the total number of early syphilis cases by region, gender of sex partners in years at these slides here. Obviously, this is too much to see, but when you get these slides, you can look at how those differ by patient population in your region in California. Next slide. And congenital syphilis followed a similar pattern. It hit an all-time low in the early 2000s. That lasted until about 2011, 2012. And then congenital syphilis incidence rates in California began to rapidly increase, and they were double those of the US by 2020. Next slide. And as you can see, similar to syphilis, hit an all-time peak in 2022, and now we're just starting to see that the trends may be beginning to change. Next slide. In looking at congenital syphilis stillbirths or neonatal deaths, similarly, a peak of 61 in 2022, and that came down to 41 in 2023. Next slide. The greatest number of syphilis cases in California occurred in Hispanic mothers, and the greatest incidence rates of congenital syphilis occurred in Black mothers in California. Next slide. In risk factors reported by mothers of CS infants in the California project area, so that means that this includes everybody in California except for San Francisco and Los Angeles, that 60% reported delayed or no prenatal care. 44% reported methamphetamine use, 19% a history of syphilis, 17% a history of experiencing homelessness, 12% incarceration, and 5% other injection drug use. And as you can see, pregnant people diagnosed with syphilis are living in a context of complex social determinants of health, including poverty, disparities in access to care, stigma, and structural racism. Next slide. And over to you, Wyatt.
Thank you so much, Kathy. So I will be taking over the presentation for the next few slides. During this part, I'll be talking about recognition, diagnosis, and treatment of syphilis in everyone, as well as people who are pregnant. That will be our focus to help with the learning process and also to try to apply what we're learning to a very real scenario. I've provided a case for you all, and we're going to be going through the case, and the case is accompanied by some questions. When I do ask you the questions, we don't have a formal audience response system, and so I will just ask you to think about the answer for a few seconds, what you might give, and then we'll go through the answers. But it's really to help you solidify what we're learning along the way. And so to start with this case, we have a 25-year-old G2P1 woman who presents to primary care after having a positive home pregnancy test. Her last menstrual period was about 10 weeks ago, but it was lighter than usual, and her periods are irregular at baseline. You do a point of care pregnancy test, and it is positive in clinic, and she would like to continue the pregnancy. 1 second. Okay, sorry about that. You gather a little bit more history, and she has a history of herpes as well as seasonal allergies, for which she takes acyclovir and pseudoephedrine PRN. She has no allergies to medications, and she has no pertinent family history. You do gather a social history, and you find that she has one male partner. They're on again, off again, and he's currently in jail, but due to be released soon. She does not smoke, and she denies any drug use, and she has not used any alcohol since she found out she was pregnant. The provider who's taking care of this patient in urgent care or in clinic doesn't provide prenatal care, and so they actually just place a referral to OBGYN, and they don't order any prenatal labs, unfortunately. But they do order a dating ultrasound just so that's available when they do see the OB-GYN. And it finds that there's a singleton pregnancy with a normal anatomic survey, and the gestational age is approximately 18 weeks and 6 days, and the placenta is normal. And so my question for you, based on this part of the case, is when should a pregnant person be screened for syphilis? Possible answers include never, during the first trimester only, during the first trimester and third trimester only, during the first trimester, third trimester, and at birth, unless there are low risk and they have a documented negative screen during the third trimester. All pregnant persons, regardless of risk behavior, should be screened 3 times during pregnancy. That's the confirmation of pregnancy or first prenatal encounter, early in the third trimester, and at delivery, or don't know. And so I'll give you let's say 10 seconds to think about that, and then I'll tell you the answer. 4, 3, 2, 1. And so the answer in this case is E. And I'm highlighting this because there have been a few changes in the last year regarding syphilis screening, especially for pregnant folks. And so I really want to focus on screening for syphilis in the coming slides. So let's talk about syphilis screening. Both the ACOG, the American College of Obstetrics and Gynecology, and more recently, as of 2 or 3 weeks ago, CDPH updated the syphilis screening recommendations for those who are pregnant. Both CDPH and ACOG now recommend universal screening, so regardless of risk factors, during the first prenatal visit, during the third trimester, and at delivery. That means every person, regardless of risk factors in California, should be screened 3 times during their pregnancy. And these are CDPH's updated syphilis screening recommendations. The first 2 here, which I'll read to you, pertain specifically to pregnancy. So the first of those is that all pregnant persons, regardless of risk behavior, should be screened for syphilis 3 times. That is at confirmation of pregnancy or first prenatal encounter, early in the 3rd trimester, and at delivery. Additionally, emergency departments and hospital-affiliated urgent cares should screen pregnant people for syphilis prior to discharge if syphilis test results are not available for this pregnancy. So those are the 2 that have to do with pregnancy specifically. There are a few more updates with CDPH syphilis screening recommendations, and they are as follows. All sexually active people between 15 and 44 years old, regardless of gender identity or sexual orientation, should be screened for syphilis at least once in their lifetime, and that syphilis screening should be offered annually thereafter, or is recommended to be offered. All people aged 15 to 44 entering a correctional facility should be screened for syphilis at intake. And then lastly, anyone who's being tested for other STIs and HIV and even Mpox should be screened for syphilis. And so all of these recommendations were changed and made with the recognition that we have increasing rates of syphilis in California, as well as congenital syphilis, and we're trying to mitigate those with these recommendations. The screening during pregnancy is supported by state legislation. This is Senate Bill 306, which states every licensed healthcare professional engaged in providing prenatal care or attending a birthing parent at the time of delivery shall provide syphilis screening and testing as outlined by the most recent CDPH guidelines, which I just went through with you. So that is a recommendation that it be every pregnant person be tested 3 times. And to help support testing as early as possible, this legislation also stipulates that this testing should occur at the time of first professional visit or within the first 10 days of known pregnancy. Okay, so that is screening and some legislation supporting that screening. I want to return to this case. Just as a reminder, this is a pregnant patient previously seen at 18 weeks gestation. They haven't had any prenatal testing ordered. They now return. Unfortunately, the patient missed their follow-up visits with the OBGYN, but they're returning at 32 weeks gestation to the local FQHC urgent care. They're complaining of a few mildly painful genital sores, and the patient's partner was recently released from jail. You do an exam, and what you see in an exam are a few what I would call clean-based ulcers on the labia majora and minora, no vaginal discharge, and when you palpate those ulcers, they're mildly tender. And so my question for you is, if this patient was diagnosed with syphilis, what stage would they have? Is it primary syphilis, secondary syphilis, early latent syphilis, late latent syphilis, or syphilis of unknown duration? Again, I'll give you, say, 10 seconds to think about that question. Great. And so the answer here is primary syphilis. And so this person has ulcers, and if they were diagnosed with syphilis, those would be likely be chancres, and so we would diagnose them with primary syphilis. But let's talk more about syphilis staging so that we can help solidify this information more, and we can learn about the other stages as well. And so starting with an overview of syphilis, the causative organism is Treponema pallidum, and this is a spirocheete bacterium. Transmission occurs through direct contact with infectious lesions like that chancre we saw before. It can also be bloodborne and transmitted from parent to fetus, which is the main topic of our conversation today. Incubation on average is 3 to 4 weeks, but it can range anywhere from 10 to 90 days. So when you're getting that sexual history, it's really important to ask about those more remote exposures. And then the bacteria causes a systemic infection with episodes of active or symptomatic disease interrupted by periods of latent or asymptomatic disease. And if we look at this diagram to the left or to the right here, you can see kind of the life cycle of syphilis. The spirocheca bacteria enters the site of inoculation. Usually that's the genitalia, but it can be any part of the body, as we'll see in just a moment. And it causes a chancre at that location. The bacteria then enters the lymphatic system to then spread around the rest of the body to infect other organs. This diagram shows the natural history of syphilis from exposure, primary and secondary syphilis, which are those symptomatic stages that we'll learn about in just a second, then latent syphilis, which is asymptomatic. And we won't talk much about tertiary syphilis today or at all. But what's important that I want to point out about this slide initially is that there are complications that can happen along the way at any stage of a syphilis infection. And the first of those is neurosyphilis, ocular syphilis, and otosyphilis, which is an infection of the central nervous system. We won't be talking about that at all today. But important to today's conversation is congenital syphilis. Anyone who has syphilis during pregnancy, there's a 80% chance that infection will be transmitted to the fetus if that person goes untreated. And this can have highly morbid results. And so it's really important to recognize those infections because they have a high rate of affecting the fetus as well. But we just saw somebody with primary syphilis, or what we suspect is primary syphilis, in our clinic. And so I want to talk more about primary syphilis. After an exposure, 30 to 50% of those who are exposed go on to develop an infection. And again, the incubation period can range anywhere from 10 to 90 days, but is on average 3 to 4 weeks. Primary syphilis, again, is that first stage of symptomatic infection, is characterized by a chancre. A chancre is a painless ulcer that's usually indurated or firm to the touch, has a clean base, so no eschar, and typically has some rolled edges. We'll look at what a typical chancre looks like in just a second. But atypically, people can have multiple ulcers, like we saw in our patient, and they can be mildly painful. And this is becoming more common these days. So it's important to keep syphilis chancres on your differential, even if you see an ulcerative rash that doesn't appear to be the characteristic chancre. Because these are painless, or typically painless, and they are in areas that we can't readily see, people often don't recognize that they have them, and they can go and heal on their own without recognition. And there may be some regional lymphadenopathy at the same time. These are very good examples of the different ways that chancres can look. So here at the top left and top right, as well as bottom middle, you have the very characteristic single clean-based ulcer. In that top left example, you can see a very good example of those rolled edges. And then we have some more atypical examples. The top middle is a perianal rash where you see multiple ulcerative lesions. This is proven to be primary syphilis. And then same with that bottom right photo of the penile shaft. And if I saw either of those atypical examples, I would probably have HSV on my differential as well. But both of these were proven to be syphilis. So I'm trying to provide you examples in which you may not think syphilis is the primary diagnosis, but you should still be thinking of it, and it should be on your differential. As I mentioned before, chancres occur at the site of inoculation, and so they can be extragenital sites. Here are really good examples of those extragenital chancres. Here are a tongue, a digit, and 2 labial facial chancres. There are other causes of ulcerative disease affecting the genitalia. Here we have HSV, and typically HSV starts with a prodrome of burning or itching. Then it develops an erythematous base with a vesicular rash on top, as you see in this left photo. Those vesicles then go onto a road, as we see in this central photo. And HSV can also affect extragenital sites. Here we have a Whitlow finger where it's infected the finger, as well as oral labial herpes, which we have an example of here, or cold sores. Mpox is another ulcerative or STI or that can cause rashes across the body as well. Typically, these have a way of evolving that is characteristic for them. They start with a macule or papule, which then turns into a pustule and develops a central umbilication or necrosis, and then scabs over and falls off. Again, anyone who's being tested for other STIs should be tested for syphilis per the CDC or CDPH updated guidelines. So hopefully we wouldn't miss syphilis even if we thought it was mpox. Okay, so that's primary syphilis and differential for you. Let's move on to secondary syphilis. Returning to this natural history, after a primary syphilis stage, usually 2 to 6 weeks later, somebody goes on to develop symptoms of secondary syphilis. Again, this is a symptomatic stage of the infection. Very rarely, but it can happen. You can have overlap between that chancre and secondary syphilis symptoms. So if somebody has a chancre and secondary syphilis symptoms, I just want you to know that is possible. But looking at those secondary syphilis symptoms, most commonly people present with a rash. This is usually a maculopapular rash involving the torso, whole body, but characteristically it can involve the palms of the hands and soles of the feet. People can also have generalized lymphadenopathy, constitutional symptoms like fevers, chills, body aches, mucus patches, condyloma lata, and patchy alopecia. I'll provide examples of those in the coming slides. Here are really good examples of that secondary syphilis rash. As you can see, it's maculopapular, involving here we have examples of the torso. Sometimes it can have an overlying scale, which you can see in all of these examples. It appears kind of dry on the scrotal rash, but although it has this overlying scale, it's not itchy. And so just to be aware of, syphilis rashes are not typically itchy. And then characteristically, it can involve the palms of the hands and soles of the feet, of which we have good examples of here. Secondary syphilis can also cause mucus patches. Mucus patches are slightly raised white or clear mucosal patches in the mouth. This includes the side of the tongue, as you can see here, top of the tongue, and the inner part of the lip are just some examples. This should not be confused with oropharyngeal candidiasis, which is caused by Candida, or oral hairy leukoplakia, which is caused by EBV, typically seen during severe immunosuppression, such as advanced HIV infection. Here we have examples of patchy alopecia. As the name alludes to, you can get a kind of patchy appearance or a patchy loss of hair. Here we have examples on the scalp, but it can affect any part of the body. Sometimes this is referred to as moth-eaten in appearance because it can look a little bit like a moth-eaten sweater with that patchy appearance. And then condyloma lata are another symptom of secondary syphilis. And these are typically slightly raised, fleshy to gray in color lesions affecting the moist areas of the body, typically the perianal, as we have in these two examples to the left, perineal and perivulvar areas, as we have an example to the right. These can be very easily mistaken for HPV warts, but again, first-time presentation for an STI that you think might be HPV warts, you should work them up for secondary syphilis. Of note, condyloma lata are very infectious, and so that's something to be aware of. The same for mucus patches. Here are an example of those HPV related warts or anogenital warts. Typically, these have a more verrucous or cauliflower-like appearance, as you can see in the example to the left here, although that is very exaggerated. A more subtle example is that to the right on the shaft of the penis, but also sometimes these can be more flat in appearance or sessile, so they can be hard to differentiate from syphilis, secondary syphilis, and so it's really important that you work people up appropriately and keep syphilis on your differential. Okay, so that's the symptomatic stages of syphilis, primary and secondary. Let's talk about latent syphilis real quick. So after somebody goes through the symptomatic stages of syphilis, their symptoms will disappear on their own without treatment. And when somebody has syphilis, but they do not have symptoms, this is known as latent syphilis. There are generally two categories of latent syphilis. The first of those is early latent syphilis, and this is an infection in which there's evidence that infection occurred or was acquired within the last 12 months. If there's no evidence of that infection being acquired in the last 12 months, or we know it was acquired longer than that ago, then that's called latent syphilis or late latent syphilis or syphilis of unknown duration. So there's early and late latent syphilis. Notably, sometimes people, especially early in infection within that first year of an infection, they can have secondary syphilis symptoms. They can go away. They enter kind of a latent phase, and then those symptoms can come back. That happens in about 25% of people, and it's most common in the first 12 months of an infection. Okay, but let's talk a little bit about what the evidence or what evidence you need to determine somebody has an early latent syphilis infection. This is really important because determining whether it's early or late determines what treatment you give and how you give it. And so evidence of an infection within the last year, somebody must meet one of the following or more. They must have a negative syphilis serology from the last year, which then turned positive. They must have a known contact to an early syphilis case. They could have signs or symptoms of primary or secondary syphilis that would tell you they were early on, because those symptoms usually occur within the first year or do occur within the first year. Or if they've had syphilis before, they must have had a fourfold increase in their titer within the last year, or only one possible exposure, which was in the last year. If any of those things are true, then you can say they have early syphilis. If none of those things are true, then they have late latent syphilis or syphilis of unknown duration. Okay, so that was staging for syphilis. Let's return to our case just for a second. So just as a reminder, we have a pregnant patient who's previously pregnant patient. Actually, no, she's currently presenting to us. She's pregnant. She's at 33 weeks gestation, and she's had no prenatal care. And she's presenting with a genital ulcerative rash to the local FQHC urgent care. And so the provider who's seeing her in urgent care, maybe they're a family physician, who knows, but they recognize this patient hasn't had any prenatal care, and they want to make sure that patient gets the labs they need. And so they order all the first trimester and second trimester labs for them. That includes a CBC, a GLT, type and screen, etc., all the infectious labs, including a rapid syphilis test, which they have in clinic, and they also add on a urine drug screen. And the results come back with a urine toxicology, which is preliminary positive for amphetamines, and rapid syphilis is reactive. I'll talk a little bit more about point of care and rapid syphilis testing in just a second, but I just want to show you what a positive result might look like. This is an example of the syphilis health check. Okay, and so as I mentioned before, this provider recognized the patient had no prenatal labs, and so they ordered first and third trimester prenatal testing. My question for you is which tests done during this visit were not indicated as part of routine prenatal labs? A, Hep B and C serology, B, syphilis, rapid syphilis testing, C, rubella IgG, D, urine toxicology, or E, quantiferon. I'll give you 10 seconds to think about that. 3, 2, 1. Okay. And so the answer in this case is urine toxicology. And you might be thinking, why on earth are we talking about urine toxicology? This is supposed to be a presentation on syphilis and congenital syphilis. Well, as Dr. Jacobson mentioned earlier in the presentation during the epidemiology section, there is a large overlap between people affected by congenital syphilis and substance use. And so this is an intersection that we commonly encounter in our practice and in trying to reach patients who need treatment for syphilis during pregnancy. And so I want to give you a little bit of information on this and also kind of emphasize how unnecessary urine toxicology screens can be more harmful to patients and families than they can be helpful. And so this is actually an excerpt from Do No Harm, which is by Heather Briscoe at UCSF, who specializes in this work. And it says, while substance use is evenly distributed across racial demographics, in pregnancy, Black and Indigenous women are tested at higher rates, are referred to CPS more often, and are more likely to have newborns removed as a result. And that child removal perpetuates generational trauma, creates medical distrust, makes families less likely to access medical care, housing resources, and mental health treatment, and leads to higher likelihood of family stress and disruption. And so when not necessary, UTOX can actually be quite harmful for families. And when we think about somebody who is diagnosed with syphilis and we're trying to help them access care, it can be disruptive to them accessing care and making sure they get the treatment they need during pregnancy to prevent congenital syphilis outcomes. And so I want to provide you with a few considerations, and this is really important, especially for if maybe you're part of an institution who makes Eutoxine part of the workflow and requirements. And I would encourage you to kind of challenge that at your institution if that is the case. But I just want to provide you with a little information. And first and foremost is that California does not require biologic testing of mothers or newborns with suspected substance use. Unfortunately, in California, though, many institutions, especially safety net hospitals, use biologic testing to identify and report families who are at risk. And because safety net hospitals are cared for more BIPOC people, this consequently results in the test and report practice that contributes to racial disparities in child welfare reporting. Additionally, not only in California, but ACOG, which is a national organization, has thoughts about this too, which I want to provide you, and that is that drug and alcohol use during pregnancy is a health concern that is best addressed with education, prevention, and community-based treatment, not with punitive drug testing and reporting laws or criminal prosecution. So hopefully if you're in an institution that does require this testing, you do have a little bit more information so you can challenge that. But I'll get off my soapbox now and we'll return to syphilis. And so my next question to you is, remember we had a pregnant patient who had point of care testing that was positive in our urgent care, our FQHC urgent care. And so my question for you is, can we confirm syphilis based on this reactive point of care test alone? I'll give you 10 seconds to think about that. Okay, hopefully you thought of an answer, and the answer in this case is no. And so point of care testing is a little bit more novel, and some of you may have heard of a new over-the-counter point of care test for syphilis. And so I'm going to talk a little bit more about it, but that's why I'm presenting it here, just so you can get a basic understanding of point of care testing. But as mentioned, syphilis cannot be confirmed based on point of care testing alone. But what's really important is, especially for those who are at high risk of morbidity, like pregnant patients or people who may not have the ability to follow up readily, this CDPH does recommend empiric treatments based on point of care testing while you await confirmatory testing, really to get that treatment process going and engage people in care. Okay, so let's talk about syphilis diagnostics. The gold standard for diagnosis of syphilis is dark field microscopy from a lesion or a PCR of that lesion. Unfortunately, those things are not widely available, and so what we're left with is serologic testing. There are generally two categories of serologic testing: non-treponemal tests, which I have outlined in orange here, and then treponemal tests in blue. Starting with non-treponemal tests, the two available tests are RPR and VDRL, and these measure antilipoidal antibodies, which are nonspecific, and they can be positive in other conditions like autoimmune conditions. This returns a quantitative result, so a number to you, in factors of 2, which is 1 to 2, or 1 to 1, 1 to 2, 1 to 4, etc. And the higher that second number, the higher the level of antibodies in somebody's serum. And this value increases with reinfection, and it decreases after treatment or over time, even if somebody is not treated. And because you have this variation in values and it's quantitative, this allows for assessment of disease burden, treatment adequacy, and reinfection. Now, looking at treponemal tests, there are many treponemal tests, but some examples include TPPA, FTA antibodies, EIA, and point of care tests, which we'll talk about in just a second. These detect antibodies that are specific to T. pallidum, the causative organism for syphilis. These results are qualitative, meaning it gives you a yes/no answer that is typically reactive or non-reactive. And the antibodies usually stay positive for the remainder of one's life. For both of these reasons, they're used to identify a history of an infection, but they can't be used to identify treatment adequacy or reinfection. And so there are generally two ways to diagnose past or current infection with syphilis, using these serologic tests. And I'll provide you with some algorithms on the next slide to help guide you through this diagnostic process. But the two general ways we diagnose syphilis The first is with a reactive non-treponemal antibody and a reactive treponemal antibody. And so one of each is positive. And with both of those, you can diagnose a past recurrent syphilis infection. The other way is with two reactive treponemal antibodies. An example is a positive EIA and a positive TPPA. These are syphilis testing algorithms. We have two algorithms that help guide you through the diagnosis of syphilis, the traditional algorithm on the left and the reverse screening algorithm on the right. With the traditional algorithm, you start with a non-treponemal test, the RPR or VDRL. If it's negative, they screen out of the algorithm. They're unlikely to have syphilis. But if it is reactive, then that has to be confirmed. Remember, we need two positive tests, treponemal and non-treponemal. So we go on to do a treponemal test, usually a TPPA because it has high sensitivity and specificity. If those are both positive, we've confirmed a past recurrent infection. If the second one, the TPPA, is negative or non-reactive, then that's likely a false positive RPR. Moving on to the reverse screening algorithm. Of note about the traditional algorithm, if somebody is very early in their infection, sometimes the RPR can be negative. Or VDRL. In those cases, you can repeat the RPR or VDRL 2 to 4 weeks later, and it should become positive if they have been infected with syphilis. Moving on to the reverse screening algorithm, as the name alludes to, this rather than starting with a non-treponemal test, this starts with a treponemal test. Typically, it's an EIA or CIA. These are immunoassays that are they're easily batched and a little bit cheaper to run, which is why they're used. If that is negative, they screen out of the algorithm. If it is reactive, then you need to confirm again. And so you get that non-treponemal test to get a non-treponemal and treponemal test for confirmation. If it is positive or reactive, then you have confirmed a past recurrent infection. But if it's non-reactive, you're stuck in a little bit of a sticky situation in which you still need to figure out if they've had a history of syphilis. And in that case, what you do is you do a second different treponemal test. So not a second EIA or CIA. You do typically a TPPA, do the high sensitivity and specificity, but it can really be any of those treponemal tests. If that is reactive, then you have the two treponemal tests you need for diagnosis of a past recurrent infection. If it's non-reactive, then that's likely a false positive EIA or CIA at the beginning. Of note, people with a two positive or two reactive treponemal tests but a negative non-treponemal test, this can happen in two situations. One, as I mentioned before, can be very early syphilis infection. Sometimes that occurs when you're screening someone very early because these treponemal tests typically become reactive a little bit earlier. The second is just in somebody with a very old untreated infection or treated infection. Over time, RPR and VDRL can decrease even without treatment and become non-reactive. And so in that case, you really want to ask if somebody's had syphilis before and if they've been treated. If they've never been treated before, you would want to treat that person for late-latent syphilis. Okay, so those are the algorithms. I want to talk a little bit about point-of-care testing, just because you might have heard about point-of-care testing in the news recently with the release or the FDA approval of this new over-the-counter syphilis test, which in this is to the very right, the first-to-know syphilis test. But there are actually two other point-of-care tests, including the syphilis health check and the DPP HIV syphilis system. Those two are CLIA waive tests, which means they can be performed under a CLIA waiver by a certified healthcare provider. And in some situations, they can also be performed by disease investigators and HIV counselors. Contrary to that, the over-the-counter test is a consumer product, and so come this month, actually, those are entering drugstores around the US, and people and patients will be able to buy them off the shelf and test themselves in their home. The important things to know about these tests is that they all are treponemal tests. And so when you think about that algorithm, these fill the block of the treponemal test, but alone, just like if we did a solo treponemal antibody, these would not be diagnostic. And so, but because they are treponemal tests, they can be used as part of that algorithm for the diagnosis process. But anyone who has a point-of-care test that is reactive should have confirmatory testing, usually with an RPR and a second treponemal test. But again, as I mentioned before, for those who are at high risk of morbidity, like pregnant patients, or those who might have difficulty following up, we do recommend treatment based on these point-of-care tests while you await confirmatory testing. For people with a history of syphilis, they can actually have positive RPR and VDRL, those non-treponemal titers, for months to years after treatment. And so it's really important to be able to interpret RPRs and VDRLs in subsequent titers so you can recognize reinfection as well as treatment adequacy. And so in somebody with a history of syphilis, what you need to do is be able to compare titers, prior and current titers, to assess for that reinfection and treatment adequacy. Any twofold change in titer is generally considered within the margin of error for a test. These are typically manually read, and so there is some error in how that can be done between labs and differences between labs and times of day. But what that twofold change looks like is, so if we have these titers to the right here, if somebody came into you and they typically have a 1-to-1, maybe you're seeing them every 3 months for PrEP or something like that, and then they have a 1-to-2, generally you wouldn't worry about that. You would just test them again in another 3 months if they required that screening. But what we do worry about are fourfold changes. These are considered significant, especially if they are sustained for 2 or more weeks. A fourfold change, in this example, would be a 1-to-1 to a 1-to-4 or higher. So anything that's greater than that would also be concerning. And that would be concerning for a reinfection. And then when we think about treatment adequacy, we're looking for a fourfold fall, but I'll talk about follow-up in just a second. When we're comparing titers, it's really important, and especially when we're seeing patients who might go between institutions, it's really important to know that RPRs and VDRLs are not comparable. They shouldn't be compared. And so if you have somebody who's coming to you with RPRs, but you do VDRLs, just know you can't compare those two things. Okay, so that is syphilis diagnostics. I have another question for you. So the provider is told that the patient's point-of-care syphilis test is reactive. Remember, this patient had no prior prenatal care and is presenting at 33 weeks gestation with an ulcerative genital rash. The provider orders confirmatory RPR and TPPA. My question for you is, what is the best way to proceed? A, discharge the patient and have them follow up with their prenatal provider to determine treatment if treatment is needed. B, record the patient's contact information and have them return, call them and have them return if the confirmatory test is reactive for treatment. Or C, empirically treat with benzathine penicillin G, 2.4 million units in a single dose. I'll give you 5 seconds to think about that. Great, and the answer in this case is C. As I mentioned before, patients who are at high risk of morbidity or may have difficulty returning, we are encouraging empiric treatment based on point-of-care testing. This patient has an ulcer, so we think they have primary syphilis, and so we would treat them with a single dose of benzathine penicillin G. We'll talk about treatment in just a second. But returning to this case, just as a reminder, this is a pregnant patient at 33 weeks who's had no prenatal care and is presenting with genital ulcers, and has a reactive point-of-care syphilis test and a point-of-care UTOX with amphetamines. The provider informs the patient of the reactive point-of-care syphilis test and positive amphetamines on urine toxicology. The patient is fearful because CPS was involved in their prior pregnancy and she denies substance use. The provider recommends treatment for syphilis before the patient leaves. But unfortunately, while the injection is being prepared, the patient disappears from clinic and does not return. So really, I want to drive home that point that when UTOXs are added and they're not necessary, they can really be harmful to patients and families and disrupt patient care when it's truly necessary. Okay, but let's talk a little bit more about syphilis treatment and follow-up during pregnancy. Starting with treatment of syphilis in pregnancy. And treatment of syphilis in pregnancy is actually the same as when somebody is not pregnant. And that is when they have primary, secondary, or early latent syphilis, they get 1 dose of benzathine penicillin G. When they have late latent syphilis or syphilis of unknown duration, they get 3 doses of benzathine penicillin G. It's an IM injection of 2.4 million units. It's really important on the day of treatment that you also get a titer. Even if that titer was a week ago, your last one, those titers can change quickly, especially in early disease. So it's important to set that baseline so you know what you're comparing to. And then I just want to say this is that outside of pregnancy, things like doxycycline and tetracycline are options, alternative regimens for people, but during pregnancy, those are contraindicated. And so penicillin is really the only thing you should be treating pregnant patients with who have syphilis. And if they do have an allergy to penicillin, they should be hospitalized for desensitization and then get that treatment. As with all syphilis infections, treatment can cause a Jurich-Herxheimer reaction, which is kind of a cytokine response, causing fevers and body aches, etc. During pregnancy, this can cause things like contractions, but this should not delay treatment, or the worry about this should not delay treatment. What you should do is just tell patients this is a possibility, and they start having worrisome symptoms like fevers and contractions, they should return to labor and delivery for evaluation. Again, it's not very common, and the risk of morbidity from untreated syphilis is much higher. Treatment intervals during pregnancy are very important, and that is repeat injection should happen every 6 to 8 days. The ideal dosing interval is 7 days, but you do have a small window. If you look at CDC guidance, they allow for up to 9 days between doses, but California preliminary data suggests that there's actually an increased risk of congenital syphilis if doses are given on 9 days. So we really emphasize the importance of keeping that 6 to 8 day schedule. Importantly, try to keep it at 7 days. So when a patient is treated, they should have their follow-up appointment for 7 days later for the next injection before they leave your clinic. There are, regarding follow-up for syphilis during pregnancy, the repeat RPR should be gotten no earlier than 8 weeks after their treatment. If they're already at 24 weeks gestation, we recommend just repeating the RPR at delivery and not sooner. Everyone with syphilis during pregnancy should have a RPR gotten at the time of delivery, which should be easy to remember now that we're recommending syphilis testing or screening for everyone at delivery. And of note, you may not see a fourfold decline in syphilis titers before delivery, and that's okay. But what you do want to make sure is you're evaluating for reinfection or evaluating for possible reinfection. If you do see a fourfold increase in titers on that repeat titer, that could be indicative of reinfection or untreated neurosyphilis, so you should evaluate for that. Then anyone treated for or found to have syphilis during pregnancy after 20 weeks gestation should have a fetal ultrasound to assess for signs of congenital syphilis. As I mentioned before, you may not achieve that fourfold decline in RPR or VDRL before delivery, and that's actually okay. There are other measures to determine adequacy of syphilis treatment during pregnancy, which I've listed here. The first of those is that treatment must be initiated 30 or more days prior to delivery. And so if you're treating someone for latent syphilis and that 3 injections, that just means the first injection needs to be given on day 30 or more before delivery. There must be no concern for reinfection, and there should be no sustained fourfold increase in maternal RPR, which could be indicative of a reinfection. Pregnant folks will eventually become non-pregnant, so it's also important to know how to follow up non-pregnant folks who have had a history of syphilis. Again, you want that day of treatment RPR or VDRL, just so you can have a good baseline. Anyone with primary or secondary syphilis should have repeat titers at 6 and 12 months after treatments. And then people with latent syphilis, any asymptomatic stage, either early or late, should have repeat titers at 6, 12, and 24 months. And you give them that whole period, so either 12 months for the symptomatic or 24 months for the asymptomatic, to achieve a fourfold decline in or more in titers. And if they achieve that fourfold decline, that is indicative of treatment success. Okay, returning to our case, I just want to provide you a reminder that this is a pregnant patient with a history who had a reactive point-of-care syphilis test at 33 weeks gestation, and no treatment was administered, unfortunately. But she does re-present in spontaneous labor at 39 weeks gestation to L&D. And the provider does routine syphilis screening upon arrival to L&D in accordance with CDPH guidelines. And the EIA is reactive, and the RPR is 1 to 32. The delivery is a normal spontaneous vaginal delivery without any complications, and the ACOG scores are 8 and 9. On a neonatal exam, though, the provider does note copious nasal secretions as well as some irritability. And because the parent's RPR was reactive, RPR was also gotten on the baby, and that was 1 to 8. And so my question for you, based on this information, is given the information available, how should we proceed? Possible answers include the newborn's RPR is 4-fold lower than the parents, so they do not have congenital syphilis and there's nothing to do. The newborn should have a CSF analysis, CBC, and long bone radiographs to determine treatments. Or C, the newborn should be treated with a single dose of IM benzathine penicillin G before discharge. I'll give you 10 seconds to think about that. Okay. The answer in this case is B. This infant has symptoms of congenital syphilis, and they should be evaluated appropriately with a CSF analysis, CBC, and long bone radiographs. So now we have an infant with congenital syphilis. I'm going to pass it back to Dr. Jacobson. And Dr. Jacobson, I'm sorry I went a little bit over, but you have 9 to 10 minutes.
Okay, great. Yeah, thanks, Wyatt. I think that should be sufficient time, and thank you for the syphilis presentation. So let's talk about congenital syphilis for a little bit. Infection during pregnancy can occur at any gestational age in any stage of parental syphilis infection, including primary, secondary, early, or late. If infection goes untreated, 80% of infections will also infect the fetus. Up to 40% of pregnancies of people with untreated syphilis may be stillborn or result in early infant death of the infant. So there are potential short and long-term sequelae, even when an infant has been recognized and treated. Next slide. So we're going to just go through some of the signs and symptoms of early congenital syphilis, which is thought to occur between birth and age 2, starting with gestation, as we just mentioned, preterm. They can have hydrops fetalis. They can have intrauterine growth retardation or be small for gestational age. They can have constitutional symptoms, including fever and irritability. And as you may recall, our infant had some irritability. And they can have skin and mucosal findings, including rashes on their soles. They can have desquamating rashes, as you see here. They can have these copious nasal discharge, like our infant did that delivered for this particular mother. They can have mucus patches, and they can have adenopathy. Next slide. They can also have neurologic findings and musculoskeletal findings, including abnormal reflexes or motor development or failed hearing screens. From a musculoskeletal standpoint, they can have osteochondritis, periostitis, or pseudoparalysis. Next slide. They can develop a pneumonia alba, a myocarditis, and from a GI standpoint, pancreatitis, hepatosplenomegaly, or GI malabsorption. Next slide. So now we're going to walk through how you know, for instance, with this infant, how you would have known to actually do the lumbar puncture on this infant. Next slide. So all infants and birthing parents, i.e. the mother, need a serum RPR or VDRL titer drawn at delivery. Next, and so, and there's different criteria and different pathways to determine what the workup is of the infant and whether or not the infant gets treated. So we're going to look first at infant criteria. Infant criteria includes any CS findings on physical exam. So if you saw any of those findings that we just walked through, that infant would meet infant criteria. Some findings are more likely early on than later findings. You want to go back just a moment? Yeah. If the infant has a titer 4-fold higher than the birthing parent's titer, and recall mother had a titer of 1 to 32. This baby had a titer of 1 to 8. So that's actually fourfold lower. So it wouldn't necessarily fit this criteria, but the fact that it met the first criteria with CS findings on physical exam in and of itself puts it into the infant criteria. Also, if you have a positive dark field or PCR on the placenta, cord lesion, or body fluid, or a positive silver stain on placenta or cord. Next. So if you can say yes to any one of those above, and in our case, it would be CS findings on physical exam, then this infant meets scenario 1. And so this infant needs the lumbar puncture, they need a CBC, and they need long bone x-rays, and then of course, any other tests that you think are clinically indicated. And this infant, because this infant meets infant criteria, you're going to do that workup, but this infant is going to get treated with aqueous crystalline penicillin G, which is IV penicillin, 100 to 150,000 units per kilogram per day, administered as 50,000 units per kilogram per dose, IV every 12 hours for the first 7 days of life, and then every 8 hours thereafter for 10 days total. So that's infant criteria. And again, if you say yes to anything above, you're doing the CBC, the CSF, and the long bone x-rays because you want documentation, but that infant's going to get treated regardless of the results of those findings. Next.
Dr. Jacobson, you have 5 minutes.
Okay, thank you. Okay, next is and I think this slide is the most critical, so if we run out of time for the other slides, we'll keep focused on these. Next is if they don't meet infant criteria, do they meet maternal or birthing parent criteria? And so was the mom inadequately treated or not treated? In this case, the mom was never treated. Although the infant already met infant criteria, so you don't even have to continue down this path. But let's say the infant didn't meet infant criteria, then you're looking at what about the birthing parent or the mother? Was she inadequately treated, not treated, or maybe she tells you she was treated, but you can't find documentation of that anywhere, or she was treated with a non-benzathine penicillin G formula. There is a benzathine penicillin G short-acting or CR versus a long-acting version. Really important that if you're treating anyone for syphilis that they're getting that long-acting version of benzathine penicillin G. And then was that treatment initiated more than 30 days before the day of delivery? If it was less than 30 days of delivery, so if you can say yes to any of these in the orange box here, then this infant falls into scenario 2 with possible congenital syphilis. You're going to do the same workup as you did for the infant that met infant criteria. And next box, if you find any abnormalities or you can't get the results for some reason, maybe you can't do a lumbar puncture or something, or the follow-up of that infant is uncertain, then that infant also gets the aqueous penicillin G for 10 days. If, on the other hand, there's no abnormalities and the infant follow-up is certain, then for these infants, you could get away with giving a single dose of benzathine penicillin G at 50,000 units per kilogram per dose times 1. Next slide. Once the infant has been treated, then you want to make sure that you do an RPR at 3 months, really like every 2 to 3 months. And it should be decreasing by 3 months and be non-reactive by 6 to 12 months. If it's reactive at 6 to 12 months, then you want to repeat the CSF and retreatment may be needed. Next slide. And if I can just get through this last part of this slide, that would be great. Next. So let's say the infant doesn't meet infant criteria. It doesn't meet the orange boxes of the parental or maternal criteria. There are some other ways that the infant may still be determined to be a congenital syphilis infant. And this is our third scenario where maybe the mother was adequately treated and treated with the right medication and treated sufficiently for her stage. And that treatment was initiated more than 30 days before delivery. And you had no concern in talking to the mom that she may have been reinfected or had treatment failure. Next. So the answer in these cases, yes to all of the above. You don't need to do any additional workup for this particular infant. Next. But you do want to review the parental titers and see if there's, was there a fourfold or greater decrease in titer after treatment of early syphilis, or if the mother had later unknown duration syphilis, is that titer, if it's an RPR less than 1 to 4, even though it may be fluctuating between 1 to 1 and 1 to 2, or is the VDRL less than 1 to 2? Next. And if it's no to all of that, then this infant would receive that single dose of benzathine penicillin G, the 50,000 units per kilogram times a single dose. If it's yes to that, so there was a greater than fourfold decrease, and the titer is stable below 1 to 4 for RPR and 1 to 2 for VDRL, and you think that this mom will bring this infant back, then you do not have to treat that particular infant. Next slide. So again, you want to do follow-up RPRs on those infants every 2 to 3 months. And yeah, thank you. And this particular slide is saying, even if you have an infant that was not treated, and even if you want to do an RPR, should be, yeah, the RPR should be non-reactive by 6 months. If it's reactive at 6 months, you want to repeat the CSF exam and consider retreatment. Yeah, okay. And if let's say you decide that the infant doesn't need treatment, and the RPR was non-reactive at delivery, and mom did have syphilis, but you decided that this infant did not meet criteria for treatment, then you still want to do a follow-up RPR at 3 months in that infant, because it can take up to 90 days for a RPR to become positive. And that infant may have been incubating that syphilis, and you didn't yet get that positive RPR test result. Next slide. So in summary, syphilis presents differently in different stages of disease, and as you have seen, can easily be misdiagnosed for other infections. If left untreated, patients progress through stages of active disease, interspersed with periods of latent disease. The diagnosis of syphilis involves both TREP and non-TREP tests, and the outcome of untreated primary, secondary, and late syphilis during pregnancy can be severe, including miscarriage, early infant death, and congenital syphilis. Screen pregnants for syphilis at their first prenatal visit, during their third trimester, and at delivery, and that's for all infants. And with that, we'd like to take any questions, and also thank you for attending.
Thank you so much to both of you. That was fabulous presentation, and there's been a very active Q&A, and I've answered a lot of the questions, but not all of them. I'm also going to put up a slide just kind of with reminders, but as I'm doing that, one of the questions that was asked I thought was really interesting was related to syphilis testing and wondering whether does doxypep affect syphilis testing? I don't know which one of you might want to address that as I get my slide up.
Does it affect syphilis testing? Was that the question?
Yes.
Yeah. I think the story's not on that yet. Would be probably the first answer. That there are some anticipations that it may affect the RPR value. The RPR is the titer that's 1 to 2, 1 to 32, etc. There are some concerns that it may have some impact on that titer. Wyatt, I don't know if you want to add anything to that.
Yes, I have nothing to add.
Then there's another question related to contacts. So how would you, what is the treatment given to someone who has a syphilis exposure? The question is BIC, 1 dose of BIC recommended for that?
Wyatt, you want to take that?
Yes. Yeah, I can take that question. And I removed the contact slide, but for somebody who's had an exposure to an early syphilis case within the last 90 days, that is one dose presumptively. Even if they're testing, you want to get testing if you can, but if you can't, that's okay. You're treating them presumptively because it may take 90 days for that testing to turn positive anyway. If that exposure was more than 90 days ago, if testing is easy and you can do it and they can follow up easily, you can get testing and then treat based on that, because we would expect the testing to result reactive if they actually have an infection. But if they can't, say they have difficulty following up or they're at high risk of morbidity, like a pregnant patient, then you should also just treat them presumptively. That's 1 dose of BIC again. And then anyone who's a long-term partner and their partner is diagnosed with late latent syphilis, late latent syphilis is not infectious. And so what you can do is test that patient and then base your treatment based on those results. Yeah.
Great. Perfect. Thank you for answering that. All right, this is moving us back to congenital syphilis. So this has to do with treponemal tests. And the question is, for someone who was born with congenital syphilis and then treated, they're wondering whether their treponemal test might remain positive for life. And the question relates to possible foster care situation where the person might not know of all their medical history. That was the full question. Any thoughts on that?
So an infant that had congenital syphilis and was treated for congenital syphilis.
Correct.
Yeah, that is a great question, and it reminds me a lot of the early days of HIV and prevention of mother-to-child transmission and what those labs were going to look like. To my knowledge, that's a great question. That the TREP test should remain positive. That's a good question. Because the infant doesn't have all of their antibodies at the time of delivery. When you think about adults, we assume that their TREP tests remain positive. So we might have to get back to you on that, unless Wyatt, you've got something to add there.
Oh, no, this is a great question. And at a recent presentation I gave, somebody asked the same question. So maybe this is that person. And I've talked about it with a bunch of people since because it's such a good question. And the takeaway from those conversations is essentially we don't have data on that scenario. We don't know. But the thoughts and speaking with a lot of different people who specialize in this is it might depend on the scenario. And whether that was like a true CS infection and they mounted an antibody response, in that case, we would expect their TREP test to be positive for life, maybe. But maybe also we're treating just because of really high suspicion, and what we detected were maternal antibodies, and those disappear from the neonate system at 12 to 18 months. So to answer your question, we don't have data on that, but it's certainly possible that they could remain reactive. And so I would say if you're seeing somebody who's in foster care and you don't have that information, try really hard to get information on their neonatal treatment period.
That's great. Thank you both. All right, so this relates to syphilis testing, and this is maybe a California specific question. Can a DIS perform the first to know syphilis test when doing an HIV, HCV as a certified test counselor? I don't know if either of you know the answer to that. That probably relates to laws in California.
Yeah, I think I can take this one. So when you're talking about an over-the-counter or self-test, in order for it to be an over-the-counter test, it has to be performed by the individual being tested. So the individual could test themselves under the observation of the disease investigator, and they could, watch the individual testing themselves. So the patient is testing themselves. They can watch them go through the procedure, make sure that they are doing the test correctly. The individual has to read their own test result, but the disease investigator can verify their reading. We went through a lot of this with COVID, and how you separate out a point of care and a self-test. This is a self-test. So a self-test requires somebody to both take their own specimen, process the test themselves, read the test themselves. But it's fine to have somebody sitting there next to them and observing them to make sure they do all of those steps correctly and verifying the read that the patient first did themselves. I hope that is helpful.
That's great. Very detailed. So thank you for that. What's your approach dealing with twofold increases, even though we know that we're looking for a fourfold increase? In pregnancy, how would you manage somebody with a twofold increase?
I can take that while Dr. Jacobson is working on her mic. And so twofold increases again are within the margin of error. And so if you're really worried about that patient, I would ask them more about their potential exposures. Again, untreated syphilis is highly morbid, and so you do want to catch it if it is the case. And if you have a really high suspicion for a potential exposure, over-treatment is much safer than untreated syphilis during pregnancy. And so if you treated that patient just based on that and you think, oh, they have a known exposure, I'm just going to treat it. You should be treating anyway if they have known exposure. I wouldn't fault you for that. But if you're kind of on the fence, you're like, I don't. If they have no risk factors, I would just continue monitoring that. I would repeat it at their next check during their pregnancy. But if you're kind of in the middle and you're like, maybe they were exposed, what you can do is just repeat it in 2 to 4 weeks, and it will increase at that point, and you can treat based on that.
That's great. I've been answering a bunch of these questions in the chat, in the Q&A, and I would have said just to repeat it in 2 weeks and see whether it remains the same or whether it drops back down, or if it rises. And so just if you have that 2-week interval, and I completely agree with that. So thank you. Let me just see if I can pick out a couple other questions. This is an epi question, wondering why there was a syphilis increase in women, from 2013 to 2018 more than in men. I'm not sure. I wasn't actually.
I know what you're talking about, and you're probably talking about that slide with all the graphs. That's really hard to read. But yeah, it's a great question. As far as why we have increasing syphilis cases in females as compared to males is really hard to say. And some potential for that is that in the male population, especially MSM population, we had regular screening for a long time as part of routine care, and we may not have had that for the female population. Kathy, I don't know if you have anything else to add. I don't think we know the answer is the conclusion, but the question was, why are we seeing increasing rates in the female population for syphilis as compared to the male population?
Well, actually, we are seeing increasing rates in both. If I didn't share this data today, but males make up about 4 to 1 male to female cases. Both have been on a significant upward trend until just recently. We certainly believe that the fact that things are starting to trend downward a little bit has at least in part been related to doxypep, which we didn't talk about today, but that's not really answering your question other than, once cases go up in males, they're going to gradually start to go up in females or vice versa, just they started going up in males first.
All right. Well, thank you both. I think we're at our time because it's 1:20. And I really appreciate both of you being here today for this fabulous presentation and all for the active Q&A.